Hello, my name is Grace Namorato, and for my Case Connections number 4, I will be discussing cases 2 and 3. So let's take a look at case 2. Here we have a 4-day-old infant that has demonstrated high levels of phenylalanine during a newborn screening test. Her diagnosis is phenylketonuria, also known as PKU. And this causes issues with the metabolism of our essential amino acid phenylalanine. Under normal conditions, phenylalanine is hydrolyzed to our non-essential amino acid tyrosine by enzyme phenylalanine hydroxylase. This enzyme requires BH4 as a cofactor, and deficiencies here can lead to PKU. The biochemistry of PKU begins with mutations on the PAH gene that generates phenylalanine hydroxylase, which converts phenylalanine to tyrosine. Tyrosine then becomes our essential amino acid. Without working phenylalanine hydroxylase, the amino acid phenylalanine builds up to toxic levels in the blood and tissues. Seizures, delayed development, behavioral problems, intellectual disability, and psychiatric disorders are common symptoms of PKU. Babies born to mothers with PKU are also at significant risk of intellectual disability. Nerve cells are particularly sensitive to phenylalanine levels, which explains how PKU can cause brain damage. The range of severity of the condition is due to mutations on the PAH gene that allow the enzyme to retain some activity. After a phenylalanine-restricted diet, therapy was initiated at 14 days of age. The plasma phenylalanine levels dropped within normal range, confirming that there was indeed an issue with the enzyme. The second potential cause of PKU could come from issues with the required cofactor BH4 that is needed to metabolize phenylalanine to tyrosine. Deficiencies with BH4 could lead to elevated levels of phenylalanine, thus causing PKU. These patients are not clinically responsive to phenylalanine-restricted diet, but need specific substitution therapy. Taking a look at infant B, he has also been evaluated for suspected PKU. BH4 loading test is performed on both of our patients, infant A and B. Here we can look at the graph, patient A in the blue, patient B in the orange. And by looking at this, we can see that there was a steady decrease of circulation of phenylalanine with BH4 administration in infant B. And this indicates that the cause for infant B's PKU diagnosis is actually a deficiency in the cofactor BH4 since the levels of phenylalanine have been lowered. Deficiencies in cofactor BH4 was not the root cause of infant A's PKU diagnosis. That concludes case 2. Now looking into case 3, we're looking at gout. So for this case, we have a 47-year-old man who presents with severe pain in his right toe. Based on physical examination and laboratory findings, he is diagnosed with gout. His blood samples suggest elevated plasma urate and below normal levels of urinary uric acid. Gout is a disease resulting from the deposition of urate crystals caused by the overproduction or underexcretion of uric acid, decreased salvage of purines, or overproduction of purines. The best explanation for the presentation of gout in this individual would be overproduction of purines. The disease is often associated with elevated serum urate levels. The main cause is being either lower excretion of uric acid, higher synthesis, or both. Metabolic situations with higher production and circulation of such acids are accompanied by the hypoexcretion of uric acid in urine, indicating that there could be deficiencies with glucose 6-phosphatase and fructose 1-phosphate aldolase. Deficiencies involving glucose 6-phosphatase from gluconeogenesis or glycogenolysis traps glucose 6-phosphate in the cells, and it is either oxidized through glycolysis or the pentose pathway, or increase in substrates will lead to an increase in PRPP to increase nucleotide production, thus increasing purine synthesis. This is associated with lactic acidosis, which elevates the renal threshold for urate, increase the uric acid plasma that is seen in our patient. The underexcretion of uric acid can be explained by the competition from the body trying to excrete both lactic acid and uric acid. So looking at the impact of high fructose intake on gout presentation, our patient claims that he drinks between 4 to 5 liters of soda daily, and this could have significant impacts on this patient's presentation of gout. With fructose or high fructose corn syrup being the primary sugar in most sodas, a high fructose intake could elevate plasma urate levels. Fructose increases fatty acid and triglycerol synthesis, VDL secretion, and increases LDL cholesterol. Fructose loading of the liver causes sequestration of inorganic phosphate glucose 1-phosphate and diminishes ATP synthesis. As a result, there is less inhibition of de novo synthesis of purines by ATP, and uric acid formation increases. Fructose-induced hyperuricemia is associated with a decreased renal uric acid excretion, which is consistent with the urinalysis. Decreased salvage of purines cannot be a root cause for this patient's gout symptoms. Diseases involving decreased salvage of purines typically manifest between 3 to 12 months of age. Major characteristics of decreased salvage of purines include overproduction of uric acid, motor and cognitive disability, and self-injuring behavior. Our patient only exhibits one of these characteristics. The next would be decreased urinary excretion of uric acid, and this is primarily caused by excessive alcohol consumption. The metabolism of excessive alcohol increases lactic acid production, which does compete with uric acid to be excreted. And the levels of uric acid here caused from excessive alcohol consumption is much higher than the levels from overproduction of purines. So that concludes my case connections for this course. I hope that you enjoyed it, and thank you very much.